Pleural effusion is characterized by as the word effusion says, there is a large amount of fluid which gets collected inside the pleural cavity. That is the thoracic cavity, which is between the lung and the external environment, like the skin, subcutaneous tissue, the rib cage. So the cavity between that, where the lung stays, is called as pleural cavity or the thoracic cavity. That is very important to keep the lung inside, as well as to help the expansion of lung, to maintain the expansion of lung inside. And there is about 0.25 cc per ml per kg of normally the fluid is produced by the lung border itself. That is the parietal layer of the pleural cavity itself, which is a layer towards the ribs. Towards the lung layer is called as a visceral layer, or the viscera is nothing but the organ layer. It doesn't produce any pain. It has no pain receptors. It has no production receptors. But the production cells which are present, the mesothelial cells which are present on the parietal layer. That normal fluid gets aggravated or increased in some conditions like infections, inflammations, and in malignancy. It could be infective, inflammatory, traumatic, autoimmune drugs, and sometimes collagen vascular disease and other such diseases, which may lead to increased amount of fluid which may get collected inside this thoracic cavity. It could be infective, which can be bacterial, viral, fungal, or parasitic. It can be traumatic, traumatic because of road traffic accidents, which can cause any damaging or piercing injury to the lung, which may lead to hemo or blood to collect inside it, called as hemothorax. If there is pus in the lungs, in the lung cavity, it is called as pyothorax. If there is air in the thoracic cavity, it's called as pneumothorax. So any kind of thing which enters the lung cavity, the thoracic cavity will develop some kind of thorax, and that is in this case, pleural effusion is fluid. So it can be infective, inflammatory, autoimmune disease like rheumatoid arthritis, SLE, Sjogren's syndrome will lead to development of this fluid, which may collect over time in the thoracic cavity. There are drugs also which may lead to development of these, but drugs are very less. They are only those long-term drugs which are given to the patient, maybe cancer patients, maybe autoimmune patients, etc. And this fluid which gets collected may over time become an empyema, which is thickened pleural fluid, pleural effusion, which may require certain surgical interventions, certain minimal access intervention, which includes one of those includes thoracoscopy, which is putting a small thoracoscope inside the lungs and getting out all the mushy secretions from the pleural cavity. Usually, this patient would clinically would present with fever and cough and slight breathing difficulty on the left side and the right side of the chest. The effusion can be bilateral also in the case of cardiac. So there are certain causes like cardiac causes or thyroid causes which may also lead to pleural effusion. But in the case of single pleural effusion on one side or right side, there will be pain on the chest while breathing. Initially, they'll have the pain because during breathing, the pleura may rub with each other. That is, the parietal pleura and the visceral pleura may rub with each other when the fluid is very less. When the fluid starts increasing from mild to moderate, there is no more pain. There is dull aching pain, which is a dull sensation in that part of lung. If the patient tries to sleep on that side, but won't be able to sleep because the lung is not able to, So if I have an effusion on the left side, I will try to sleep on the left side so the right lung starts to improve. It expands. That is how the posture the patient takes. On clinically, when it is done on investigations, we can go for a chest X-ray, which will give us an idea of an S-shaped or a pot belly sign, which may be a locular effusion, loculated effusion, or a very proper effusion, which have this ellipsoid sign on the surface, which will be a diagnostic of having the pleural effusion. Also, post clinic. Along with that, when you consider other scans, which include CT scan, this is usually not done by me. Though I'm a pulmonologist, I prefer an X-ray, and post X-ray, once the fluid is removed with some with some technique, which I'll explain later, then I go for a CT scan to look for any pneumonias which are present in the lungs. So CT scan is another option which you can go for. Another one is a USG thorax, which we use to quantify the fluid, and then USG guided syringe and a needle is taken to tap it, and the blood or the effusion or the pyothorax, whatever it is, try to remove. This is how we go for with the diagnosis of pleural effusion. Any pleural effusion cannot be treated with the help of antibiotics alone. This has to be done in a clinical setup in the hospital where we do a USG thorax, get the area where the fluid is there. We put a 18 number needle with a syringe and we insert it with local anesthesia, of course, with all the proper technique in which all sanitary techniques which we use. And the patient doesn't require any sedation for this, and we put a needle and we get the samples out. After the fluid is out, we keep on removing that fluid continuously with a external IV set or connector, and the fluid keeps on coming out till we can drain about 1.5 liters per day. 1 to 1.5 liters can be safely removed. During procedure, if the patient coughs or pain feels a little bit pain, it is very natural to have, but the pain increases, we can immediately abandon the procedure and we can do that the removal of the fluid. If there is a lot of fluid which is present and it is coming again and again after 3 to 4 tappings also it is not going down, it is filling up again, you will have to put an ICD or the intercostal drainage tube. Now, for suppose if the fluid is very thick, you put a needle, you find that it is all pus which is not coming out easily. You have to put a lot of pressure in pulling that fluid out. It means you have to put ICD, but ICD is also sometimes not able to remove everything. So we give a small incision and we put a thoracoscope, which can be rigid thoracoscope. A thoracoscope is just a stiff ICD kind of a thing, which is a stainless steel one, and which has a camera with a camera in front. We put that, we go inside, we look entire chest, and we remove all the fluid and all the septations, and then get out the fluid. And then after that, we put an ICD and close it with the help of a suture, or device has come new which closes the sutureless device, which closes the ICD tube without any sutures. Which we do the investigations for that also, in which the fluid is sent for the further investigation for TB, infections, malignancy, and all, which gives us a better insight about the infection. It is inflammation, autoimmune, or malignancy, and then accordingly we can treat the patient with antibiotics, chemotherapy, radiotherapy, or we can directly just put the Lasix. Sometimes it is not a non-infective one. It could be cardiac, it could be CKD, and it is continuously coming, and you've put an ICD or you've done a tapping, and it is just can be treated by treating the underlying cause, that is the cardiac cause or the kidney cause. To prevent tuberculosis or any other infection, you have to have a mask so that it doesn't cause infections. And sometimes this fluid usually occurs with a foci which is present in the lungs. So if you have a small pneumonia, it can definitely lead to a pleural effusion. Ultimately, you have to wear a mask and have to have good hand hygiene. Apart from that, there is the prevention would be that if you feel some kind of symptoms like it is a cough for more than 1 week or 2 weeks or more than 1 week, at least you should visit a pulmonologist. Within the first 2-3 days, if you have a cough, it is never bad to spend some pulmonologist opinion, cash or money, because that will give you a better insight. It will be very fast. It will not be like you try these medications or you try that medication, or you're by yourself trying some medications from the pharmaceutical stores or medical stores. It will be better to prevent that, to get yourself checked up by doing an X-ray or meeting a pulmonologist itself. Rest, mask up, and hand hygiene and other hygienes can be taken into consideration.